have the privilege and pleasure of introducing our presenters this morning. Before we get to our presenters, we'll begin with our land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. This morning, we're going to be hearing about the sexual assault and abuse care program at CHEO, something that many of us don't think about very often, maybe don't want to think about, but obviously a very important service. And we're going to be hearing from Marita Smith, who's a registered nurse who has worked in the ED at CHEO for the last decade in various roles, including in a research capacity. She has continually pursued ongoing education, with her main area of interest being sexual health, and sexual abuse care. In 2015, she became a sexual assault nurse examiner and is currently completing a certification in sexuality health education from Options for Sexual Health based in British Columbia. Last March, she took on a care facilitator role with the sexual assault care program and continues in this role as co-lead of the program with a specific focus on education and research. And Alessandra Ricci is a pediatric emerge physician working at CHEO and has been the medical co-lead for the sexual assault care program for the last 2 years. So lots of experience here with our presenters. And Marita and Alessandra, I turn it over to you.
Thank you so much, Dr. Berman, for that introduction. I want to do a little bit of an addition to that land acknowledgement. When we think about the land acknowledgements that we're giving, I think it's really important to think about what that means for our care. And so in the care that we provide in our program, we recognize that Indigenous communities experience a really disproportionate amount of sexual violence. And indeed, Indigenous people make up 4.9% of the Canadian population, but up to 50% of people who are trafficked in Canada are Indigenous. And we cannot accept those, the state of affairs. And so in our program, we're continually working to build relationships with Indigenous partners in our community so that we can continue to create spaces that are safe and appropriate for care, recognizing the population that we serve and the reasons why some of them are not accessing care. So I also just want to recognize before we continue that this presentation, as well as the program, is very much a team effort. There were lots of folks that contributed to this presentation, and you'll hear from some of them throughout. And so when I'm talking about other folks' roles, it's usually because they've provided me with information and content. So thank you to everyone who contributed. In terms of our content today, we're going to look at what the sexual assault nurse examiner role is, because as Dr. Berman said, a lot of folks don't always know how we work and sort of what we do. And we'll talk about our model of trauma and violence informed care and why that language is really important. We'll talk about some of the other roles and care that are offered by folks who are not nurses in our team, and some of the ancillary services and other folks at CHEO that provide a lot of care and support to our population. We'll talk about some of the specifics of forensic nursing versus the nursing care that we give, and some reasons to refer and how to access our care. As we mentioned, this is recorded. We don't have anything sort of graphic or specific to specific patients or anything like that, but it is heavy content. And we also know that in our communities in Canada, about 7.8% of Canadian children under 15 experience sexualized violence. So that means, I don't know how many people are in the group here, but it's quite likely that some of us have been affected by sexual violence in our childhoods or in with people that we know. So please do take care of yourself. If you need to step away or take a break, please feel free to do so. So our program is affiliated with the Ontario Network of Sexual Assault and Domestic Violence Treatment Centres. This is a network that was started in the 90s in Toronto and has expanded to 37 centers across the province. It's funded by the ministry, and so we do have funding for our program that comes through the network. And we'll talk a little bit more about, what's funded and what's not. And the mandate there is really looking at these three realms of health, psychosocial, and forensic needs. And as you'll see in the different cases we go through and the care that we offer, those are the three areas that we're really focusing on. We're also have to mention that we get an enormous amount of support and mentorship from the Sick Kids program, the SCAN program. And just like many other folks at CHEO, we have very close relationships with them and are very well supported. And so we're just very lucky in Ontario to have this incredible network of expertise that gives us access to a lot of support. In terms of the population that we serve, of course, we provide care for anyone in an acute phase. So in that, the 12-day number that we have here, that's not an arbitrary number. What does acute mean, right? That really is just a number that looks at forensic evidence collection. So 12 days is the longest length of time that we would be able to collect forensic evidence physically from an individual. And if folks present after the 12-day mark, we absolutely do have services that we offer. It might just look a little bit different, and we won't necessarily push to get them into emerge right away after that time. We also provide services for victims and survivors of intimate partner violence or teen dating violence. And I won't be covering this in this presentation because we have another presentation for ED rounds right after this for any of you that are popping over. And my counterpart, Lynn Bates, will be presenting on that topic. The last section I have here on this slide is high-risk youth and youth affected by sex trafficking. The number, unfortunately, of youth that are impacted by sex trafficking has gone up significantly. We know that Ontario is one of the highest provinces affected by this issue, and we'll talk a little bit about how we're trying to move a little bit upstream, just given the numbers that we're seeing and the decreasing ages that we're seeing. This is a very high-level overview of who is part of the team. So, of course, we have our nurse examiners, who are ED nurses. We have myself and Lynn, who are the care facilitators. We have some social work partners. We get some support in the acute phase from Carol Monceau, who's the ED PICU social worker, not a network funded position, but provides us with a lot of support and follow-up for our patients. And we'll talk about the other roles for counseling and Alessandra's role, she'll talk to you about in a few minutes. And then we also have some incredible admin support that we're very grateful for. In terms of the nurse examiner role, so this is really an advanced practice nursing role. It requires a lot of not only education, but also ongoing competency building. So the way that we would start at CHEO is by orienting a nurse to our program and just talking about the medical directives and our process, our documentation, how we work. We would provide them with some opportunities to do some cases with us. So just like a buddy shift as a nurse. And they will also begin to work through some coursework from the network that has been developed by the network. There's about 40 hours of coursework in addition to 40 hours of virtual now, SANE training. And that also includes learning how to conduct a genital exam and a speculum exam. And unfortunately, because those classes have moved virtually, we don't have the same opportunity to learn that skill in person. And so our wonderful gynae service at CHEO has been kind enough to have our nurses come over there and follow them and have some opportunity to learn those skills. There's a couple of reasons why nurse examiners work very independently. One of them is because we recognize that when folks have a traumatic experience of sexual assault, they really don't want to be repeating their story, right? If somebody has experienced that, they don't want to repeat the story to a triage nurse and a medical student and the 3 other nurses and the ways that folks often move through the emergency. And so with a SANE, we can meet the person right as they arrive or right after they're triaged and really follow them through their visit and be a central presence with them and bring in other services as needed, but really allowing them to not have to repeat their story. The second reason why that's really important is because having different accounts of an event, the way that sometimes different providers might note different details or note things a little bit differently in their documentation, that can actually cause significant issues down the road in court, because a defense attorney might look at that documentation and say, this is not a credible individual. And so therefore, they're unable to get the justice that they deserve. So having a singular set of documentation is going to be a really common theme throughout this conversation. The directives allow us to really follow that patient all the way through. So all the way from history taking, head to toe assessments, testing and treatment that we'll talk about, referrals and discharge, as long as they fit within the parameters. And certainly we'll bring in an emerge physician or a crisis worker or any other services that are necessary. Along the way, of course, we have to maintain our competency. And so when we see patients individually, we will be reviewing with a physician in emerge. We will review the cases together as a team. And if there's questions around genital findings or complications within the case, we can always tap into other partners like our child and youth protection physicians, or like I mentioned, our sick kids partners can also support us as well. There's always going to be ongoing education. We have lots of opportunities, monthly education with the network. We have nursing communities of practice. We're constantly reaching out to community partners like our police service, our Crown's office, and many others to maintain our cross education and to maintain those relationships. This kind of work is not the kind of work that can be done in silos. It has to be done as a community. And since about the 90s, the SANE role, which really was only developed in the 70s, since about the 90s, we've been really well respected and recognized within the legal system in terms of the evidence that we provide. And certainly with our community partners, we're lucky enough to have some really wonderful relationships with our community partners. Again, this is an overview of some of the care that we offer, and you're going to see all of these elements in some of the cases that we see. And each individual will be, we'll take a history, we'll share the information of the kind of services that we offer, and then we'll decide together which ones are appropriate for each patient. All of our care is going to be shaped by the principles of trauma and violence informed care. And the reason that's really important is because we're not just talking about, the trauma of a car accident or the trauma of maybe a childhood illness or something like that. It's really violence that's happening within systems. And so that's a really important piece to understand. And certainly the values of the network and the standards of care that are set by the network are really closely reflective of these 4 principles. The model of care that we use in our program, again, is shaped by these principles. And I just put it in this sort of visual so that you can see how survivor agency is really at the center of everything that we do. We know that folks who've experienced any kind of sexual abuse, whether it's ongoing childhood sexual abuse or whether it's a one-time assault in adolescence, there's a significant loss of agency. And there's also probably some factors and beliefs that have played into the events that occurred. And so we're going to work together with that individual to help them build their agency through these methods. Before we even have a conversation with someone, before we ask them to share something that's really difficult and traumatic, we need to make sure that there's safety and trust that's established. And in order to do that, we have to understand some of the systemic impacts that might be at play. So we already talked about the disproportionate impacts of sexual violence on Indigenous communities. And we have to think about things like intergenerational trauma. We have to think about things like racism and homophobia and how those things impact the care that we offer, as well as impact the experience of the survivor. So from the get-go, we're going to work for that individual to build that trust and safety. And we're going to think about how we can provide them with the maximum amount of choices that are available to them, and let them know as much information as we can about the decisions that they make, so that they know what the potential outcomes might be. And it's impossible to do this in a complete way, But when folks are thinking about things like police reporting, we have to give them an idea of what that might look like. All of the decisions that we make are going to be made together. We don't make unilateral decisions for this population the way we might if somebody was in an emergency situation and needed surgery, for example, and we're just going to tell them this is what you need. In this forum, we're going to give them the information and work together to make the decision that's best for that individual. And all the way through the process, we're going to look for their strengths and continually affirm their autonomy. So for someone who's 2 or 3 years old, that might just look like letting them know what step is going to happen next in the exam, and allowing them choices like, do they want to sit with mom or lay on the bed for their exam, things like that. We're also going to do consent education as we move through the exam process. We're going to model consent as well as talking about it explicitly, because children who've experienced sexual violence desperately need to understand that their bodies belong to them and learn how to affirm their own agency. These are just some examples of how you can do what we just talked about. And so if you're ever in a situation where you're caring for someone, and you quite likely have been, whether you know it or not, these are just some of the examples of things that we can think about. You know, an environment where there's a shared patient room versus a private space, very different situation. Thinking about what their bodily needs might be. Do they have pain needs that need to be addressed before having a conversation? Are they comfortable? Do they have enough to eat today? And do they know that they can revoke consent? Do they know that we can start an exam and get halfway through, and if they're uncomfortable, we stop and everything stops? And again, that's consent teaching at the same time. I won't go through every detail, so we're moving into some of the roles here. The 2 things I wanted to highlight are the first one, which is really the meat and potatoes of the work that we do, which is the cases. So when folks either call the office, we might get a referral from a social worker, police officer, or a parent. And so we'll make a plan of care, whether they need to come in person, whether we can provide support over the phone, if it's just some referrals that they need. They might come in to see us in person, and then we'll do some follow-up afterwards. And this might be as simple as a visit with a phone call to let them know what their lab results are and check in to make sure everything's okay. Or it might actually be months of ongoing collaboration and case support for someone in the community who maybe has housing needs, maybe they're in group care, maybe they need to have some addiction resources, and that can take quite some time. The second thing that I really wanted to highlight is the idea of relational and vicarious trauma support. This is a really, really important part of this work. We know that nurses who care for people who've been sexually assaulted have a really high rate of compassion fatigue and burnout. And the highest rate of burnout is in nurses who work pediatrics and work in emerge at the same time. And that's our SANE nurses. And so we have to really think about how we can create a sustainable environment for our staff so that we don't lose staff. Because as you heard, it takes quite some time. It takes a couple of years really to be really competent and confident to practice this independently. So we do a lot of things like formal and informal debriefs are one of the really important parts of supporting our staff. And I also wanted to mention that one of our social workers, Emily Locke, has created a presentation that was actually really, really helpful for us. It invites us to learn and reflect on self-compassion and explore how to debrief in a way that reduces the spread of vicarious trauma. So if I see a case where there was a whole bunch of horrific details and I call Lynn and say, oh my gosh, I just had the worst case, it was so horrible, and these are all the things that happened. Now she's just as traumatized as me. So we want to think about how we can access support in a way that doesn't spread more trauma. And so this presentation was actually really, really helpful. And Emily wanted me to let you know that if that's something that you think might be helpful for your team, if you think you would benefit from having a conversation about self-compassion and low impact debriefing, you can reach out to her at the email on the slide there. In terms of the social work counseling role, this is also a really important piece of the care that we offer. According to our network standards that you can see there at the bottom, all clients that are seen through the acute service of the SADV are prioritized to access confidential trauma-specific counseling. So we have a 0.3 FTE funded for counseling from the network. But as you can imagine, just like every other area of mental health, the demand is always going to exceed our capacity. And so we do have to have some criteria for intake into that stream. And so we've really looked at this acute phase. And now, again, we're using the word acute, and it's not going to be 12 days, because in this case, we really want to target the peritraumatic phase. And so what the social workers will do is they'll do a CAT screen. And if you don't know what that is, it's a measure of potentially traumatic events and post-traumatic stress symptoms. And so they'll look at the CAT screen of the folks that are waiting for counseling. And the hope is that the assessment of that peritraumatic experience in the acute period following the event will help us to identify the individuals that are at greater risk for developing PTSD and make sure that they're prioritized for support. Anyone who doesn't fit that criteria, they're not out on the street. We will certainly work with social work and our community partners. And of course, one call, one click to make sure that they have supports that they need. And the social workers have also come up with this idea of a parent psychoeducation group, really just looking to fill some of those gaps where folks might be waiting for services and just provide a little bit of support for them navigating a stressful situation and how to support their youth. So it's actually on hold right now, but hopefully we'll be starting back up again soon. In terms of Alessandra's role, I will let her do the next couple of slides.
Yeah, thank you very much, Marita. So yeah, this program is quite unique at CHEO in the sense that it's a nursing-led program, the only one or one of the few nursing-led programs. So really the medical director role, I always say it's a bit of a co-lead kind of role in the sense that it's really the same that are the content experts, and they're the ones that are providing the direct patient care. In some centers like Sick Kids, they will have some nurse practitioners, but most sexual assault nurses throughout Ontario are RNs, which means that because they're providing the direct patient care, they need medical support for all the testing that is being done, like hepatitis B serologies, chlamydia and gonorrhea testing, and everything that involves any dispensing of medication. So, which could be, hepatitis B, immunoglobulin, or vaccines, or medications to treat STIs. So, a big part of my role is really to review and maintain those medical directives with the SANEs, so that they are up to date and that they allow them to do their work as seamlessly as possible, at least from that point of view. We then do weekly case reviews where we look at the cases that have been encountered during the week and talk about certain challenges. Many of these cases overlap a lot of different fields that can go from the medical to the psychosocial to the sometimes we have to involve other services such as gynecology, adolescent medicine. And so I can also help collaborate with the other MDs in the different departments. And then I'm always available as a medical consultant during the case if there's anything that exceeds the scope of the same nurses. And then we do presentations such as this one to educate the staff and trainees about the role of SANEs and the program at CHEO. You can go on to the next slide. And then I also wanted to introduce the role of myself, but of all the physicians in the emergency department and how we collaborate with the SANEs. So I would say there's oftentimes two different types of scenarios. Either a patient comes in and they're primarily a medical patient in which the emergency department physician is taking care of that patient the way that we would for any other patient in the emergency department. And then we consult the sexual assault care team, who then will come in and assist us with certain aspects of that care. Or it may be the opposite, where a patient comes in as a patient that is direct to the sexual assault care team. But however, there may be certain things that exceed the scope of the SANES. For example, if the patient is having any strangulation or ligature remarks, then that is now a medical issue. And in which case, then they will essentially consult us and we will take care and manage those patients. There is always a physician MRP. So in the end, the cases are reviewed always with a physician in the emergency department. But I would say for the great majority of the cases, it is the nurses that are providing the direct patient care. And we are really just there as a supportive role.
Thank you, Alessandra. So now we're moving into our cases. So I just want to clarify, we are recording this. These are not directly taken from patients for privacy reasons, but these are just reflective of common themes that we see and, common situations that are just sort of put together. So in this case, we have a 14-year-old female brought in through EMS. Her vitals are stable. She has some superficial wounds on her face, and she's complaining of sore throat and neck pain. The triage nurse noticed some scattered petechiae to her face as well. It's also noted she did disclose that she was drinking at the party and smoked, but she's able to have a conversation. Her GCS is 15. She had disclosed to EMS a physical and sexual assault, but wasn't sure who the assailant was. So right off the top, I don't know if I can see the comments here, but is there anything that you're thinking about, or what's sort of the first thing that comes to mind in this case? Maybe Dr. Berman can let me know if there's anything in the comments, but yes, so somebody, exactly, that's exactly what I was hoping you'd pick up on. So in this case, the concern is that there might have been a strangulation event. And so I just wanted to highlight that as something that's really important. If anyone comes in with a physical or sexual assault, we really need to move to screening everybody for strangulation. It's something that's becoming more common in the youth population. In terms of our not only with sexual assault, but it's just a very common thing that's happening. It's been normalized a lot for youth. And so we need to be really conscious of screening just because of the serious medical events that can happen, even with minimal external signs and symptoms. So in terms of management, there we go. So in this case, as Alessandra mentioned, because there's medical needs, this is not going to be a direct to SANE, but of course we want to be notified as soon as possible so that we can work with the team to, look at what are the priority goals and what needs to be done when. So of course, the trauma assessment, head injury assessment is going to be a really, really big priority here. They're going to be a CTAS 2. They're going to have, most likely this patient will get a CT angio of head and neck according to the CHEO protocol. If somebody has a strangulation event and has any symptoms at all, they will get a CT angio of head and neck. And if the symptoms are severe enough and there's enough concern, then we would need to monitor them overnight through an admission. So in her case, we'd want to make sure her pain is treated. Let's say we do the CT angio and it's all negative and her pain is treated. So we're going to continue to work with the medical team as they assess her, but some of the things we might offer are there in the list. We might include social work. We'll do screening for self-harm or suicide risk, either social work or us. We'll think about the more complete history of events and whether or not there's a place for some forensic evidence collection. We also do photography if there's injuries that they want us to record through that method. And then we'll talk about, what police reporting might look like. In this case, she came in with EMS, so quite likely police are already involved, and so we can support her to navigate that process. And we'll also think about things like STI screening, prophylaxis, pregnancy testing, and emergency contraception, and also including an HIV risk assessment. One of the things that we really think about when we're talking to youth, when we're asking questions, if we're asking questions about substances, for example, we're really going to think about how that question might be understood and make sure that they understand the reason that we're asking those questions so that we're not contributing to any victim blaming that might be happening. There are times, unfortunately, where we have parents who are making really painful and horrific statements to their children and youth. And so needing to support that individual to understand that what happened to them was not their fault, regardless of decisions that they made that may have put them in harm's way, that sexual violence is always the responsibility of the person who chooses to enact it, not the victim's responsibility. That being said, we might need to have some discussion of some safety planning and some thinking about some harm reduction lenses in this case, or in a case where someone is engaging in high-risk activities, not in a victim blaming way, but in the sense of how can you keep yourself safe in future. We also might need to support them with things like disclosure to parents. Really important to know who the safe contact person is. So if that individual doesn't have a cell phone, we need to make very sure that in our referrals that we're communicating who knows about this incident. If the parents don't know, we can cause a lot of harm by calling and giving information that they're not aware of. So we always identify who the safe contact person is and make sure that that's communicated. Other referrals might be, they might get a crisis line, they might have social work follow-up. Our standard referrals will be to adolescent medicine, who is wonderful and does all of our STI follow-up and can support with things like contraception, if that's something that the youth is interested in. And then we talked already about the pathway for counseling. Some of our patients need to be also seen by CYP or at least reviewed in review committee. And anyone who started on HIV PEP is going to get an ID referral so that ID can follow them for that medication. So in this case, perhaps the individual did want to go forward with an evidence kit collection. And so it's always going to be consent-based. There's a lot of sort of myths and misunderstandings about the evidence kit that come up. And often we find parents come in and they'll say, you know, police sent me here to do a kit. And they need to know that that's a conversation that we have with the youth. And we make sure that they understand what those implications might be. And that we make that decision together according to what they feel is in their best interest. And that, again, follows those trauma-informed guidelines. There are some timelines that we follow. So we mentioned the 12-day timeline already. That accounts only for folks with a vagina who have had internal vaginal penetration. They could potentially find DNA up to 12 days, but anyone with a penis or anyone who's a prepubertal where there was no penetration, there won't be any indication for evidence collection after 72 hours. So those timelines are important to know if you're referring someone, just in terms of how fast they need to be seen. We also need to have enough information. So a parent coming in with a concern, you know, their 2-year-old came home from dad's and the vulva is red. It's a very common sort of presentation. And that's not enough for us to go ahead and collect a kit. We need to have some sort of clear disclosure. Or in some cases, we will be able to collect a kit without a disclosure, but we have to have a lot of really, we have to have a really good rationale to do that. A kit can be empowering for someone to feel like they're taking some of the, you know, events into their own hands and doing something that might bring them justice. It also can be really re-traumatizing. It takes a lot of time. It can take hours, depending on the complexity and how that person is feeling. And so it can be something that's really difficult for people to go through. In some cases, folks aren't ready to make that decision about a police report. About 87% of sexual assault happens within families or within a close social circle. And so that can be really complicated. It can be really complicated to decide whether or not you want to report a family member to police. And so in cases where people aren't sure, we do have the option to freeze evidence at CHEO and hold it for them for up to usually 6 months to a year. So that they have some time to make that decision in a way that isn't pressured and isn't in that sort of traumatic phase. If you're someone who is working in a rural area, or you're a resident who may end up working in an area at some point that does not have sane staff, you might be the one who's responsible to conduct a kit. So we're happy for you to reach out to us, and we can chat further and provide you with some education. You can look through the training kits that we have and have a look at what that looks like. This is an example of what some of the kits might look like. You can see there are some swabs for DNA evidence collection. There's an enormous amount of documentation. So again, can be traumatic because we have to ask a lot of questions of the individual in terms of what happened exactly and what body part contacted where. And none of that, we often don't have to do that if we're not collecting evidence. And so those are just things to be aware of. So the second case, I have a 13-year-old non-binary youth who disclosed a sexual assault a couple days before. They've already given their statement to police. So in this case, most likely the police have called us and have said, you know, I have someone coming in to see you, potentially for evidence collection and for care and support. In this case, the individual doesn't have any injuries or medical concerns disclosed. So this patient would be absolutely appropriate to be direct to our team, and we might even just book them in to see us. And that means we can sort of get them right from the door, triage them, and provide them that continuity of care. We'll provide them support throughout the process. We'll take their history. We might work with social work in the initial visit to do so. We'll offer them a head-to-toe assessment, including a genital assessment, if that's something that they're looking for. It's not always necessary if there's no evidence collection warranted and they don't have any concerns, then we might not have to. Particularly in youth that are trans or non-binary, genital assessments can be very re-traumatizing as well. And so we'll of course work with them, making sure that we're using correct names for their body parts that they feel comfortable with, and making sure that they know that they're in control and in charge of what's happening. We would think about risk assessment. So what kind of contact was the assault? What kind of testing might they need? Maybe they're not really willing to do STI testing. And so one of their choices might be, well, would you like to go to your family doctor, or would you like to come back next week for testing if you don't want to do it today? We think about things like pregnancy prophylaxis if it's within the window. Again, we have a couple options for pregnancy prophylaxis, but they're all limited to about 5 days. We have STI prophylaxis that we offer. So again, that's a one-time dose of cefixime or azithromycin. And then of course the HIV PEP, and thinking about things like hepatitis vaccine and immunoglobulin if they were not vaccinated and might be at high risk. In this case, there may be relevance for evidence collection or there may not. And it looked like a pretty straightforward situation. Maybe the parents came with this child and they were supportive and they have all the supports that they need. But it could quickly turn very complex depending on the scenario around the assault and the situation that youth is in. So if they're if they're not housed, if they're in group care, if they have a lack of social support, if there are some risk factors that start to pop up for trafficking, perhaps they were interacting online with an individual, or another common story is I met someone at Rito and I went home with them. Those kinds of things would increase our concern for things like trafficking, and we would start to have some bigger conversations. If it's pretty straightforward, the check-in is going to be really quick. Within 72 hours, we try to do a phone call just to make sure they're doing okay for sleep and appetite, and looking at those acute trauma symptoms, making sure that there's not suicidal ideation that's coming up for them, making sure they have access to all the supports that they need. And safety planning. Is the assailant someone that goes to school with them? Is it someone that they're going to have to see that we need to talk about how they might need to access supports from police or something like that? On the right-hand side, you can see all the various referrals that we might make, depending on the needs of that situation. We also have the ability through our program with a CHEO cell phone to text patients in follow-up. And that's really important because a lot of our youth end up being lost to follow-up and they don't answer their phone, or they might have a web-based phone, or they just don't want to talk on the phone. And so being able to text allows us to connect with folks more appropriately. Again, when these cases start to get really complex and they are increasingly showing up with more complexity, we can't manage them alone. And so we need to be, again, doing that really robust communication and collaboration with our community partners, as well as folks at CHEO, to make sure that we have access to the services that they need. Particularly the substance use, as most of you know, that's a big gap that we have in our community. We often have to send youth to Toronto for inpatient care. And there's so many gaps in this area. And I'm really looking forward to having some more supports at CHEO. It sounds like there are some more things being built there. When we're thinking about HT and those increasing numbers and decreasing ages that we're seeing, we really need to start thinking a little bit more upstream. So rather than increasing services for folks that are affected, we need to think about early intervention. What we're doing in Emerge, and it's been working really well, is encouraging folks in Emerge to doing some education, first of all, so that people understand what to look for, and really encouraging folks to reach out to us, even if the youth doesn't make a disclosure. But if they're noticing a lot of patterns and red flags, so frequent visits for reproductive health issues, mental health, abdominal pain, STIs, things like that. And then any sort of red flags that they note in their presentation, then they might come and talk to us and just ask for them some advice on how to have a conversation. And we might not even need to get involved, or they can refer them to us so that we can provide the family and caregiver some support, even if the child or youth doesn't recognize the situation that they're in. And so these are all just really important things that we need to shift our thinking so that we're not just, again, pulling the bodies out of the river. On the topic of improving care, we're actually lucky enough to have one of our team members and one of our Emerge nurses at CHEO who is actually doing research on this topic. So recognizing that there's really a lack of research, particularly in the Canadian context, on child sex trafficking. Rebecca is working at the University of Toronto to improve clinical practice in Ontario pediatric emergencies for victims and survivors. And so her study it's really exciting, and we'll see sort of what comes out of it. But if you'd like to be involved in that study, she is recruiting for interviews and provides an honorarium as well. So if you work in Emerge, she would love to hear from you and hear about your experiences. And we're just really excited to see what comes of this research, because we know that it's going to improve our ability to practice. And so when we think about screening, and which is what her study is looking at, we think about a lot of lists of questions, right? And over time, as I've sort of read the literature and talked to survivors and talked to people and seen cases, I've really shifted from this idea of listing screening questions to a lot more of a relational approach. So if you're interested, you can look this up online. There's a really great PDF that includes a lot more details. But just quickly, this approach, instead of screening somebody who's identified as at risk, it really looks at creating this relationship with them. So whoever the provider is, sometimes it's the SANE, sometimes it's the CYC, it might be an inpatient staff of some kind, a nurse or crisis worker or physician, who really will sort of set aside some time in a safe place, in a quiet place, to have this conversation. And we can actually separate a little bit from the patient and really think about providing them some information on the topic that we are concerned about, whether it's online activity or a certain particular relationship. And we'll just talk a little bit about what trafficking looks like and gauge what their responses are as you get into the conversation. And some youth will be completely in denial and not willing to go forward. And in that situation, all we can sometimes do is provide them with information on if they feel unsafe at some point, here's a number to call. But sometimes this allows us to actually really help the youth to understand that there's something bigger going on than somebody just buying them a bunch of gifts and being really nice to them. And so sometimes this approach can help us to make that connection, and sometimes it takes many visits, right? So it might take 4 or 5 or 6 different providers asking the right questions, right? We have to think about the approach and the right questions to ask. So the next 2 cases are going to be pretty quick because we're running out of time, but these are a little bit more straightforward cases. So in this situation, someone's admitted to the inpatient unit, and they just happen to disclose a historical sexual assault on admission. So in this case, there probably isn't any indication for things like forensic evidence collection. And so the unit can consult us. And if the patient wants to see us in person and have a conversation, we're happy to come up to the unit and have a chat with them. If they're interested in something like a genital assessment, just to sort of reassure them, maybe some STI swabs, things like that, then we can certainly do that. It may not be necessary. Maybe all they need is a bit of a conversation and some referrals for support. Maybe they need some STI testing. We can certainly do that. And so we'll collaborate with the inpatient team and whoever else that individual might need. The next case is a 10-year-old male who disclosed to a family doctor. And in this case, the family doctor was able to assess them and identified that there were no medical needs, and there's nothing sort of acute that needed to be addressed. Most family doctors are quite comfortable assessing someone with a penis for sexual assault. It gets a little bit trickier with prepubertals with vulvas just because of the anatomy. And so often they will send them into us to have a re-exam and to reassure the parents and make sure everything's okay. But in this case, it doesn't sound like that was needed. And so they were referred to us. We'll offer them an in-person visit if that's something that they want. And again, if they want STI testing, if that's appropriate. It might be that in this case, all that's needed is really just a conversation with the parent to help them navigate the situation, put in some referrals to make sure that they get access to some counseling, and maybe some follow-up with Child Protective Services or police if there's an ongoing investigation. So in terms of how you connect with us, there is a couple ways within EPIC. I've put the picture there at the bottom. It's CHEO referral to ED Sane is the one that actually comes to our work queue. Unfortunately, there's also an IP consult to Sane, which does not go anywhere currently. So EPIC is kindly working hard to fix that. But right now, please only use the referral to ED Sane. The most efficient way is just to call the office, let us know that you have a patient, send an in-basket. That's the best way. But if you do send a referral, just be aware that if the patient will be discharged before we get the referral, we'll lose it. So just make sure that it goes into disposition under discharge if the patient's being discharged. But again, like the best way is just send an in-basket or give us a call. And again, we're happy to receive calls, even if you're not referring a patient and you just have a question about maybe where to send them. We're happy to answer any questions you have. This is how you get a hold of us. That is our office number, our email. At the bottom is the CHEO.net page for our program. And again, there is a presentation up there on strangulation if that's something you're interested in. There's a couple other good resources there. At the top of the page, there's a 24/7 line for the network, which is staffed by a SANE. So in the case of any gaps in our care, there's always somebody that's available to answer questions and support. Happy to send out references if folks are interested, and I'm happy to take some questions.
And for the EPIC, I'm just gonna add something for the EPIC message. It's just you can send an in-basket message. It's just ED Sane. It's ED-Sane. You can find it. It's a pool and goes to Marita, and then we're currently the care facilitators for that role.
Thanks very much, Marita and Alessandra. Lots of very useful information there. And I see Helly has a question already. Go ahead.
Hi, thank you very much for this wonderful presentation. in July 2020, we published, myself and a few residents, I was then at the University of Alberta. We actually worked with the Alberta Coalition Against Trafficking to increase awareness for learners who are participating in shifts in the emerge, for red flags on what to be aware of when a person needs to be suspected of being trafficked and sexually violated. And we actually published, we applied a module from the Fraser Health Institute with their permission and acknowledgement, obviously, and with the guidance of ACT Alberta. We showed that there was a significant increase in the awareness and understanding of, one, red flags, number two, how to, what's the next step? How do we take this person who appeared with very unclear signs and symptoms, afraid of talking about this in the emerge or any other clinical setup? I think that this is something that that can be very helpful for healthcare professionals, because they are, for the most part, the first point of entry. And at some point, people who are sexually either trafficked or sexually violated will go to a healthcare facility and may not be explicit. So I think that this lecture is was amazing, but it starts a journey to apply some knowledge to the persons who are providing care and serving the community. The other thing that I wanted to mention is that the world is a global village. There are many refugees now. And this is one of the most vulnerable populations ever. And with this, increasing the awareness is very, very important. So thank you for the talk. Happy to collaborate as needed from my EDI perspective, past EDI perspective until June 30th last summer. And thank you again.
Thank you so much for that. I would love for you to send me that lecture, and would love to talk more about what we can do to increase the education. Yeah, that's great.
Thanks, Helly, for those comments. Chris.
Hi, so I work in palliative care, and the population that I work with, for the most part, are developmentally delayed and nonverbal, but at high risk of being abused. Do you have a different approach, or can you suggest a different approach for the people who care for these children? Because I imagine it's like the 2-year-olds who have a red vulva or whatever. Like, do you have any guidance?
It's a great question, and it's not an easy, quick answer. What I will say is that we certainly do see a lot of kids with developmental delay that have concern for, and it is a very difficult approach. I had 2 or 3 recently that were similar in presentation, and the parents were specifically asking me for how to have conversations around sex education with their children who are developmentally delayed. And so as a result of that, I'm actually pursuing some specific education in that area, so that we can better develop our practice, because it's an absolutely, it's really, really important, and there's big gaps. So not a great answer, but to be continued.
Thank you.
But I think that's an excellent topic to bring up, and something that we'll see if there's any more research. Some of the cases that we have seen were children that were mobile, and it goes into the spectrum of what kind of sexualized behavior can be normal for a child of that age, and what sexualized behavior is showing as being probably outside of the keeping of what we would expect a child of that age to be doing, and what that can be concerning about exposure to either sexual acts or pornography or other things. But that is an excellent question. I don't know if there are any resources for children that are specifically non-verbal and non-mobile. We will definitely look into this because they are definitely, statistically, we know they're at very high risk of sexual abuse. So we will get back to you to see if we find anything more.
Thanks. Dr. Davies. Don, you're on mute.
Sorry, I'm wondering if there's ever situations where the police put pressure on you to report back to them and what the rules are around that. Because I always find, you know, if the police are involved, it seems like they have the ultimate authority, which I know they don't.
Great question. Absolutely something we deal with. One of the things that we've been doing is working on building our relationship with the police service. We have a very good relationship with the sexual assault and child abuse unit. And so they have a clear understanding of what our limitations are in terms of PHIPAA. So that's not generally an issue, but sometimes you'll get officers just coming in with a patient and say things like, oh, I'm waiting for you to do the kit. And we just have to, you know, respectfully explain the boundaries of our role and sometimes the tensions between their goals and our goals. But yes, it's definitely something that building more relationships with the police service. And in fact, we also do provide education to the police service at times. And so that really helps to mitigate some of those difficult conversations.
Thanks.
Dr. Batra.
Yeah, thank you. I realize this is a very, very painful situation, denial, and sort of doesn't want to remember anything in there. The lack of recognition in a way that the patient does not remember because of administration of the rape drugs there. Now, a patient is brought, a 16-year-old girl is brought to the emergency department by the friends, essentially for the infections and pregnancy assessment or control of pregnancy, but doesn't want the mother to be notified, doesn't want the parents to be notified. How do you go around with that situation?
Let me just make sure I understand. So it's a 16-year-old that does not want her parents notified.
Yes, that's right.
Yeah. Yeah, it does happen quite a lot and it's very difficult. Certainly that is their right. And what we will try to do is build a little bit of a circle of support around them. So working with social work, working with potentially child protective services in a support role, because at 16, they're not going to be mandated, but they could have a support role. And we'll work to look at, does that child have an aunt or an uncle or a friend's parent or somebody in their circle that can be sort of responsible for supporting them with medications and visits if there's more medical care that's needed. But certainly those are one of the probably most common and challenging situations that we have is just navigating differences in goals of parents versus youth. Great question.
So we are at time. Thank you for those questions and a big thanks to our presenters for covering a really challenging topic and providing clarity and resources for all of us who may encounter these situations in our clinical practice. So thanks very much, everyone, and have a great day.
Thanks so much.
Thank you.